Welcome to Let's Talk About ASD, an introduction to autism spectrum disorders. Thank you for being interested in learning more about ASD in relation to your child and for taking the time to join me today. My name is Afan and I'm an ASD consultant with Kinark Child and Family Services. During this session, we encourage you to pause as needed to reflect on information being shared, take notes that you can refer to later, and think about how this information relates to you, your child, and your family. Let's get started. By the end of this session, you will be able to better explain the common characteristics of ASD, have a better understanding of the criteria that is used to diagnose ASD, be able to discuss the changing prevalence rates, distinguish between misconceptions and accurate information related to ASD, understand what evidence-based treatments mean, and explain why applied behavior analysis is an effective evidence-based treatment for individuals with ASD. During this session, we will discuss what ASD entails, its prevalence rates, some early signs of ASD, a few potential causes and risk factors, diagnostic criteria used to assess ASD, common strengths of individuals on the spectrum, and finally, evidence-based treatments. What is autism spectrum disorder? Autism spectrum disorder, or ASD as I will refer to it from now on, is a complex developmental disorder that affects the way the brain works. It has an impact on how people communicate and interact with others. Although ASD can be diagnosed at any age, it is said to be a developmental disorder because symptoms generally appear in the first 2 years of life. People with ASD experience difficulties in two areas. The first area is social communication and social interaction, which can include difficulties with social emotional reciprocity, including the social back and forth and turn-taking in social interaction. They may struggle to understand nonverbal communication and may have a hard time developing and maintaining relationships. The second area is restricted, repetitive patterns of behavior, interests, or activities. Examples of this can include repetitive speech, movements or use of objects, and excessive adherence to routines, wanting things to stay the same, and hyper or hyporeactivity to sensory input. We will expand on these areas in our upcoming slides. ASD is known as a spectrum disorder because there's a wide variability in the type and severity of symptoms, challenges, and strengths that individuals with ASD experience. Some children and adults with ASD are fully able to perform all activities of daily living, while others require substantial support to perform basic activities. You are all here today because you have a child with ASD, and all children with ASD are different. There's a saying, if you've met one child with ASD, then you have only met one child with ASD. This is something that you want to keep in mind as we move through these slides. Every child diagnosed with ASD will have a unique set of abilities, strengths, and challenges. When we are talking about the prevalence rate, we're talking about what portion of the population has that condition at a certain point in time. Currently, ASD is the most common form of any neurological disorder or severe developmental disability in childhood in North America. An estimated 1 in 59 children are diagnosed with ASD. ASD is reported to occur in all racial, ethnic, and socioeconomic groups, and is about 4 times more common in boys than in girls. The identified prevalence rate of ASD has increased significantly in a short period of time based on data from multiple studies, including the U.S. Center for Disease Control and Prevention's ASD and the Developmental Disabilities Monitoring Network. Whether the increase in ASD prevalence rate is partly attributed to a true increase in the risk of developing ASD or on changes in community awareness and the identification patterns is not known at this time. There are several potential explanations for an increase in the observed prevalence of ASD. These include better analytic tools, which is a specific way of examining something, better identification and screening methods used by physicians, changes in the diagnostic criteria. So an ASD diagnosis is based on criteria established in the Diagnostic and Statistical Manual of Mental Disorders. Any change in these diagnostic criteria can have a great effect on children with ASD and their families. We will talk more about the changes to diagnostic criteria and the DSM in a little while. Prevalence rates could be rising due to an increased awareness among parents and clinicians, or changes in the availability and access to services. Or it could just be that there is more of a cultural acceptance of the diagnosis and an increased scientific awareness of ASD. What we do know is that the increase in cultural acceptance and the increase in scientific awareness has helped to decrease stigma about the disorder. And although it is still unclear what causes ASD, over time researchers and clinicians have become more precise in detecting and diagnosing ASD. It is clear that more children are identified with an ASD now than in the past, and the impact of this on individuals, families, and communities is significant. Throughout the session, we will be talking about some common myths and misconceptions. The first common myth is that it is impossible to spot the signs of ASD in children before 2 years of age. But studies demonstrate that for some children, behavioral signs can begin to emerge as early as 6 to 12 months. However, most professionals who specialize in diagnosing the disorder won't attempt to make a definitive diagnosis until 18 months of age. And this is because ASD symptoms can continue to emerge or disappear until around 24 months of age. At that time, clinicians believe that an ASD diagnosis tends to become more stable. Think about your child. When did you start to see those early signs of ASD? Children who would later receive an ASD diagnosis may show some of these early warning signs. Please note that some early signs may disappear over time, while others may become even more pronounced as the child gets older. A child who would later receive an ASD diagnosis may not look in another person's eyes or in their direction, may not reliably respond when their name is called, may be non-vocal or have delayed language development, and therefore may not speak. It could be that communication and speech emerges very late and that they only have a few words. It could also be that the child may not coo or imitate sounds altogether. On the other hand, they may also have echolalia, which essentially is a behavior repeating what another person says. They may not recognize familiar people, may not smile at familiar people, may not search for familiar people, and may have a similar reaction to familiar people as they do to strangers. They may regress or lose skills. Sometimes children could do something well and then a few months later are unable to do it. This may be more common with language and vocabulary. They may be resistant to change. Changes in routine may result in challenging behaviors. For example, if dad is away on a business trip and he's the one who used to put your child to sleep, going to sleep with mom could be very difficult because it's not typical routine. They may have restricted interests. The child may perseverate on particular topics or engage in repetitive behaviors such as lining up their toys. Or they may be very sensitive to sensory stimulation and input. Therefore, he or she may have an unusual and often intense reaction to sounds, smells, tastes, textures, lights, and colors. It is critical for our parents to remember that each child is different, so these early signs may or may not be present, or become apparent at different times for each child. Another common myth is that the MMR vaccination causes ASD. In fact, there have been large-scale studies that demonstrate that MMR vaccination is not related or linked in any way to ASD. In 1998, the British pediatrician Andrew Wakefield and his colleagues published a small study in the respected Lancet Medical Journal that implied that MMR vaccine for measles, mumps, and rubella plays a causal role in ASD. Since then, many large-scale studies have failed to find a link between MMR vaccine and ASD. The Lancet paper was retracted in 2010 and judged to be flawed and fraudulent. That same year, Wakefield's medical license was revoked and he was banned from practicing medicine or researching after being found guilty of dishonesty and professional misconduct. Unfortunately, the MMR-ASD myth continues to cost lives as vaccine rates struggle to reach the pre-scare levels. So if vaccines don't cause ASD, what does? At this point in time, we do not know the causes of ASD. However, there may be many different factors that make a child more likely to have an ASD diagnosis, including environmental, biological, and genetic factors. Let's talk more about these factors. According to Health Canada, there are many contributing factors to developing ASD, such as exposure to toxins in the environment, as well as biological and genetic variables. Scientists agree that a person's genetics are one of the risk factors that determines the probability of an individual being diagnosed with ASD. It is unlikely that one specific gene is responsible for this, and it is far more likely that a combination of genetic variables can be attributed to ASD. Twin and family studies strongly suggest that some people have a genetic predisposition to ASD. Particularly, studies with identical twins demonstrate that if one twin has ASD, the chances of the other twin having ASD ranges between 36 to 95%. Similarly, in families with one child with ASD, the risk of having a second child with ASD also increases. Furthermore, ASD tends to occur more often in people who have certain genetic or chromosomal conditions, such as Fragile X syndrome and Down syndrome. Additionally, exposure to heavy metals and other toxins in the environment may be attributed to ASD. Some medications, when taken during pregnancy, such as valproic acid, have been linked with a higher risk of ASD. Parental age could have an impact, as research shows that children born to older parents are at greater risk for having ASD. And babies born premature are also at a greater risk of having ASD. Research continues to explore all areas of risk factors, including genetics, neurological differences, environmental variables, with an emphasis on developing treatments and supports that can improve the child and the family's quality of life. Just as important as it is to know what the risk factors may be, it is equally as important to understand what does not cause ASD. Parenting styles do not cause ASD. In the 1950s, a theory called refrigerator mother hypothesis became popular, suggesting that ASD was caused by mothers who lacked emotional warmth. This has long been disproved. Letting your child cry it out does not result in your child developing ASD, and there is no research that shows parenting styles cause ASD. Special diets are a myth. The mother's diet during her pregnancy or the infant's diet does not cause ASD. However, some research shows that children with ASD may have more gastrointestinal issues. Therefore, identifying the foods that cause discomfort and removing or limiting their intake can decrease discomfort. However, these foods do not cause ASD, and removing these foods from a child's diet does not cure ASD. Too much screen time during infancy, whether that's a TV or an iPad, does not cause ASD, although too much screen time in early childhood may lead to vision, sleep, and social difficulties. Therefore, screen time should be limited. It is suggested that between the age of 0 to 18 months, infants should not have any screen time. Between 2 to 5 years, less than 2 hours a day of screen time should be accessed. And for children 6 years and older, limited and supervised screen time should be available. Vaccines do not cause ASD, as discussed in our previous slide. Some people have had concerns that ASD might be linked to vaccines, but a plethora of studies have shown that there's no link between vaccines and ASD. Lastly, ASD is not contagious. You cannot get it if someone with ASD sneezes or coughs near you. It's not a bacteria or a virus. Another common myth is that all children with ASD are the same. As we discussed earlier, ASD is known as a spectrum disorder because there is significant variability in the type and severity of symptoms, and it manifests in very different ways in each individual. The individual strengths and needs of each child with ASD is therefore very different from other children with ASD. Remember, if you've met one child with ASD, then you've only met one child with ASD. Diagnosing ASD can be difficult since there are no medical tests like a blood test to diagnose the disorder. Physicians look at the child's behavior and his or her social and cognitive development to make a diagnosis. ASD can sometimes be detected as early as 18 months or younger. By age 2, a diagnosis by an experienced professional can be considered very reliable. However, many children do not receive a formal diagnosis until much later. When diagnosing ASD, professionals, including developmental pediatricians and psychologists, use the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders, known as the DSM-5, produced by the American Psychiatric Association. The DSM-5 lists all the signs and symptoms of ASD and states how many of these symptoms must be present to confirm a diagnosis of ASD. It helps to ensure uniformity of diagnosis so that every physician is looking at and comparing the same set of criteria. We'll talk more about the DSM and revisions that were made to that manual shortly. As mentioned earlier, in North America, medical professionals used the 5th edition of the DSM to diagnose ASD. This was revised in 2013. At that time, a new ASD classification system was introduced. Before this revision, children could receive a diagnosis of separate subcategories, including autism, Asperger's syndrome, pervasive developmental disorders, not otherwise specified, childhood disintegrative disorder, and Rett syndrome. In 2013, with the new DSM-5, many of these subcategories were collapsed into one diagnosis: Autism Spectrum Disorders. The DSM-4 defined autism as a single spectrum disorder with a set of criteria describing challenges in the areas of social skills, communication skills, and restricted and repetitive behaviors. In DSM-5, social skills and communication skills were combined, since difficulty in communication directly affects social interactions. It can be very difficult to communicate with someone when a child may lack the understanding of social expectations and struggle in general with social skills. For example, when you're in the subway station or a party and you don't make eye contact with someone, they may assume that you're not interested in engaging with them and that you may not want to speak with them, which further limits your opportunities to communicate. Let's talk more about these two domains. Some characteristics of the social communication domain include difficulties with social emotional reciprocity, which may mean not being able to initiate a conversation or maintain a conversation. This could include not being able to initiate or respond to social interactions, or understand the back and forth and turn-taking that is inherent in social interactions. The child may struggle with non-vocal communicative behaviors, commonly known as nonverbal behaviors, inherent in social interaction. This could include not being able to understand body language. For example, not knowing that rolling of the eyes means listener did not like what is being said. Raising hands with raised eyebrows could mean what? Rubbing your chin, tapping on your lips, and looking in the distance could mean that the communicative partner is thinking about something. It could also include difficulties in developing, maintaining, and understanding close relationships. Some characteristics of restrictive and repetitive behaviors domain include restricted, repetitive patterns of behavior, interests, or activities. For example, a child may have a special interest which they enjoy talking about a lot, or spends a lot of time doing, or they may line up toys or flip objects repeatedly. Another example could be something called echolalia, where the child repeats noises and phrases that they hear. So someone with echolalia may only repeat a question rather than answer it. They may have difficulty adjusting to changes in routines, or have highly restricted fixed interests. For example, a strong attachment to or preoccupation with unusual objects. You may also notice that the child is hyper or hypo-reactive to sensory input. This could include an apparent indifference to pain or temperature, or on the other side, an intense negative response to specific sounds or textures, excessive smelling or touching of objects, fascination with lights or movement. Please take a moment to have a look at the characteristics listed in the little boxes on the side. See if you can divide them into the appropriate category. Let's see if you can determine which boxes or examples fall under the social communication domain or the restricted and repetitive behaviors domain. How did you do? Under restricted and repetitive behavior, some examples may include getting upset when routines are interrupted, experiencing difficulties when transitioning between new activities or different environments, or having narrow interests such as a specific toy or a specific topic. Under social communication, some examples may include having difficulty understanding others, that is, understanding what they are saying, understanding nonverbal cues, understanding jokes or sarcasm, and disinterest in other children or people and having difficulty communicating their wants and needs. You should also know that in order to receive an ASD diagnosis, symptoms must be present during the early years of development. Sometimes these can be difficult to spot. Social skills is a good example. If the child is isolated or does not have opportunities to engage in social behavior during infancy and childhood, the delay or lack of social skills might not be as apparent. There needs to be significant barriers or impairments in areas such as social, occupational, or other important areas of functioning. As well, the characteristics must be unique, in that a clinician should not be able to explain them by another diagnosis, such as an intellectual disability or global developmental delay. The DSM-5 includes 3 functional levels, each of which is defined based on the amount of support an individual needs to function in their community. Level 1 is requiring support. This functioning level means that without supports, the deficits in social communication cause noticeable impairments. The child may have difficulty initiating social interactions. There may be atypical or unsuccessful responses to social overtures or initiation from others. The child may appear to have decreased interest in social interactions, and rituals and repetitive behaviors may cause interference with functioning in one or more contexts. The child may resist attempts by others to interrupt rituals and repetitive behaviors or be redirected. Level 2 is requiring substantial support. This functioning level means that there are marked deficits in vocal and non-vocal social communication skills. Social impairments will be apparent even with supports in place. There could be limited initiation of social interactions and reduced or abnormal response to social overtures or initiations from others. Rituals and repetitive behaviors or preoccupations or fixated interests appear frequently enough to be obvious to the casual observer and interfere with daily functioning. Distress or frustration is apparent when rituals and repetitive behaviors are interrupted, and the child may be difficult to redirect. Level 3 is requiring very substantial support. This functioning level means that there are severe deficits in vocal and non-vocal social communication skills. Very limited initiation of social interactions occur. There is minimal response to social overtures or initiation from others, and preoccupations, fixated ritual, or repetitive behaviors interfere with functioning in all areas. There is marked distress when rituals or routines are interrupted or when a child is redirected. We have spent some time talking about the diagnosis, the characteristics of ASD, and some of the difficulties children on the spectrum may have. Now, let's look at the other side. Let's talk about some of their strengths. Some of your children with ASD may have exceptional nonverbal reasoning skills. For example, they may be able to read and navigate a map extremely well. Exceptional reading skills. For example, they may be able to read complex words and sentences. Exceptional attention to detail. For example, They may be very detail-oriented when engaging in an activity. Exceptional musical skills. For example, they may be able to play music extremely well. Honesty. For example, they may tell the truth as objectively as possible, even if it implicates them. Exceptional memory. For example, they may be able to remember experiences, conversations, visuals really well. Think about your child. What are some things that he or she is really good at doing? Alright, let's move on to our next myth. Everyone with ASD has a special savant ability. This is inaccurate. What we do know, what is fact, is that savant syndrome is a rare but spectacular condition in which people with developmental disabilities, including but not limited to ASD, have some incredible islands of genius. It is found that approximately 50% of cases of savant syndrome have an ASD as the underlying developmental disability, and the other 50% are associated with other disabilities. There are, however, 4 to 6 times more male savants than females. The condition can be present from birth and evident in early childhood. This is called congenital, or develop later in life after a brain injury or disease, and this is called acquired. With savant syndrome, skills typically occur in 5 general areas: music, art, calendars, mathematics, or mechanical and visual spatial skills. When we look at popular media, Rain Man was a marvelous movie. It was accurately and sensitively done. Yet, some people came away from the movie assuming that, like Raymond Babbitt, all individuals with ASD are savants. Approximately 1 in 10 people with ASD have some savant skills, so 9 out of 10 do not. And approximately 1 out of 1,400 individuals with developmental disabilities other than ASD do have savant skills, so such abilities are not exclusive to ASD. The next myth we're going to discuss is the myth that individuals with ASD cannot function independently. Stop and think about your child for a minute. Think about the things that your child is able to do independently. I bet you can think of a few. Some individuals with ASD already know or can learn the social communication, functional, and daily living skills to live fairly independent lives with minimal support and supervision. They may, however, have difficulty living completely independently. A study of post-high school living arrangements of individuals with disabilities found that young adults with ASD were less likely to have lived on their own than those with learning disabilities, intellectual disabilities, or emotional disturbances. Another study found that only around half of young adults with ASD had worked for pay outside the home since leaving high school. If a family is looking for options in the community, there are residential homes or group or independent living homes that offer structured and supportive environments for individuals with ASD or other intellectual disabilities. In Ontario, there are a number of resources parents of children with ASD can turn to when considering their child's future living arrangements. One good starting point is Community Living Ontario, a non-profit provincial association representing 117 local associations that advocate for and assist people with intellectual disabilities. Your local community living association will be able to direct you towards ASD-specific supports and help you understand eligibility criteria. Furthermore, once your child enters the Ontario Autism Program, your OAP clinical supervisor will address the skills for independent living, and your family support worker will be able to explore with you any available residential options in the community if appropriate for your family. For younger children, when you're thinking about independence now and in the future, remember that teaching independence is a step-by-step process that starts at an early age. When working with children with ASD on any skill, you have to plan ahead. Ask yourself, how will this look at age 5, 10, or 18? Imagining where you want your child to be as a teenager or an adult is a good motivator to teach independent skills, as it gives you a framework to set goals that will lead to increased independence in the future. How about this myth? How many of you have heard this? Since ASD cannot be cured, early intervention offers no benefit. This is absolutely a myth, and there are numerous studies with proven results that demonstrate that early intervention is critical. Studies on early developmental and behavioral therapy have shown some promise in decreasing symptoms associated with ASD and improving parent-child communication and social engagement. Young children with ASD can have improved cognitive performance, language skills, and adaptive behavioral skills through behavioral interventions using developmental and behavioral approaches. In addition to increasing the likelihood of overall school success, early intervention programs can improve communication and social skills, can have significant impact on the individual's eventual quality of life, ability to get a job, and overall independence. For those of you working with service providers so far, think about how that has helped your child learn new skills. As clinicians, we respect individuals' rights to their opinions, and specifically, for parents of children with ASD, the right to make decisions for their child regarding treatment. But it is important to be critical of information regardless of the source and to recognize that not all information on the internet is reliable and accurate. I say the internet because when you received the diagnosis, what's the first thing you did? You probably Googled ASD, right? As of now, there is no known cure for ASD, and we caution you to be wary of treatments that claim to cure ASD. There are a huge list of therapies out there. As an informed parent and consumer, you should rely on scientific sources. Scientific research provides the best and most reliable evidence of whether therapies really work, and includes direct objective observation and measurement of their treatment and results, systematic arrangement of events, procedures to rule out alternative explanations for what is observed, and repeated demonstrations by individuals working independently of one another, meaning that someone unrelated to the study could mimic the intervention and see similar results. What is ABA? The Ontario Autism Program describes ABA as an applied science based on the principles of learning and behavior. ABA uses these principles to assess, understand, and teach behaviors that are important to individuals, their families, and their communities. ABA shows us how behavior is affected by the environment. ABA therapy includes many different techniques. All of these techniques focus on antecedents, which is what happens before a behavior occurs, and on consequences, which is what happens after the behavior has occurred. One technique is positive reinforcement. When a behavior is followed by something that is valued, a reward, the behavior is more likely to be repeated. ABA uses positive reinforcement in a way that can be measured in order to create meaningful behavior change. The science of ABA includes general laws about how behavior works and how learning takes place. ABA therapy applies these laws to behavior treatments in a way that helps to increase useful or desired behaviors. ABA also applies these laws to help reduce behaviors that may interfere with learning or behaviors that may be harmful. ABA therapy is used to increase language and communication skills. It's also used to improve attention, focus, social skills, memory, and academics. A number of studies have demonstrated that ABA techniques can produce improvements in communication, social relationships, play, self-care, school, and employment. ABA is considered the only evidence-based best practice treatment by the U.S. Surgeon General and by the American Psychological Association. Evidence-based means that ABA has passed scientific tests of usefulness, quality, and effectiveness. There are several ABA-based approaches, and clinicians may choose one or the other depending on the strengths and needs of your child. Some of these approaches include DTT. This is something you would likely see in a typical intensive treatment setting. It's based on the understanding that practice helps a child master a skill. It's a structured therapy that uses a one-to-one teaching method and involves intensive learning of specific behaviors. The child completes a task many times in the same manner, and this repetition is especially important for children who may need a great deal of practice to master a skill. NET is based on the understanding that it is important to give real-life meaning to skills a child is learning. It includes a focus on teaching skills in settings where your child will naturally use them. Using a child's natural, everyday environment in therapy can help increase the transfer of skills to everyday situations and helps generalization of those skills. In natural environment teaching, the teacher or the therapist utilizes naturally occurring opportunities in the environment to help the child learn new skills. PRT is a naturalistic, loosely structured intervention that relies on naturally occurring teaching opportunities and consequences. The focus of PRT is to increase motivation by adding components such as turn-taking, reinforcing attempts, child choice, and embedding and training previously acquired tasks with the new skills being taught. It takes the focus off of areas of deficits and redirects attention to certain pivotal areas that are viewed as key for a wide range of functioning in children. In 2016, the Ontario Association for Behaviour Analysis formed the Ontario Scientific Expert Task Force for the treatment of ASD to examine the research evidence and accepted practice guidelines related to effective intervention for individuals with ASD. In 2017, ONTABA released this resource, Evidence-Based Practice for Individuals with ASD. And the purpose of this resource was to provide accurate information about behavior analysis and evidence-based practices for individuals with ASD. I would encourage you to access this resource online and review it at your convenience. As we approach the end of this session, remember, if you have met one child with ASD, you've only met one child with ASD. Your child has a unique set of challenges, skills, and areas of strengths and need. Learn what those areas of strength and special interest are and build on those. Be informed and learn more about ASD, ABA, and effective treatments. Be aware of those myths and misconceptions. Ensure that information you are reading, hearing, and learning about is reliable and based on scientific evidence. As we've already discussed, ABA is considered the only evidence-based best practice treatment by the US Surgeon General and by the American Psychological Association. I would like to thank you all for taking the time to attend this session today and hope you are leaving with a better understanding of the common characteristics of ASD, criteria used by clinicians to diagnose ASD, its prevalence rates, some of the myths and facts about ASD, what evidence-based treatment means, and why applied behavior analysis is an effective treatment. The next few slides will list some websites and agencies that may be helpful to you when looking for additional information and support in the future. We encourage you to pause the video and write down any of the listed agency names, websites, or phone numbers for your reference. This is a list of some potentially useful websites. Here you will find additional information about ASD, treatment options, ABA resources, and more. This is a list of some resources and agencies available to parents living in the York region. This is a list of some resources and agencies available to parents living in the Durham region. This is a list of some resources and agencies available to parents living in the Four Counties region. And this is a list of some resources and agencies available to parents living in the Simcoe region. Thank you again for attending the Let's Talk About ASD session.